Hi, everyone, and thank you for joining us. We're going to let everyone continue to log on and get started in just a couple of minutes. Let's go ahead and get started. Hi, everyone. Thank you for joining today's webinar, Navigating Current Updates for FQHCs. Today's program will be presented by Eric Koleska, Partner and Team Leader of FQHCs, John Barry, Senior Manager, Stephanie Nissen, Manager, and Bamasa Baylor, Supervisor in Withum's Healthcare Services team. Before we begin, I have a few notes. Today's materials can be found in the toolbar on the right of your screen and will be distributed to you after the program. Also, at the bottom of the toolbar, you will see a questions box. Feel free to send us your questions during the presentation. We will do our best to address them at the end. There will be 4 polling questions throughout the program. For CPE credit, you must participate in each poll. CPE certificates will be emailed to you within a few weeks. And finally, once the webinar is over, there will be a pop-up asking you to complete a survey of today's webinar. Please take a moment to complete it. It is our way of being able to provide you with the best and most relevant programs possible. I'll now turn it over to Eric.
Hi, good morning, everyone. Thank you for joining us today for this quick FQHC update covering the ever-changing world of Medicare, the fun and exciting 340B program, and a general update on ASC 842 accounting. When we dive into those topics, we're going to get into the changes of Medicare, how to optimize your 340B program opportunities, and discuss the current regulation changes that are going to certainly impact going forward, the revenue streams that the centers really have grown to appreciate and continue to grow overall. And then give a refresher on 842, the lease itself standard and the financial reporting requirements on it. Most of you, should have heard of this lease standard. It's been around for a while, but we're just going to give a refresher on what we've learned from the early adopters, the 12/31 year ends, as we move into the later year ends, and a lot of the centers, have different year ends, 3/31, 6/30, 9/30. Those are going to be coming up for the first time for you. So some good notes to keep in mind. We have a lot to cover, and we'll try to address in the questions at the end. And if we run out of time, we'll certainly follow up directly with the individual asking the question. So we'll move forward. So the Medicare program continues to evolve and to meet the ever-changing needs of our patient base. Certainly a group that needs and deserves good quality healthcare, and providing those services. We need to be able to evolve and dynamic for what those needs are. We're going to briefly discuss the changes that address reimbursement rates, any upcoming changes from the various appropriations acts that seems to happen annually this time of year, towards the end of every year, last year and certainly the year before, and a brief update of some cost reporting items if we have time. For those calendar year ends, you've already certainly have probably already filed your cost reports, but for those that are fiscal year ends, those will be coming up. So some quick updates there. Every year there's a new physician fee schedule that's put out. This past year's was released open for comments in July through September, and then finally issued November 2022, effective this current year. So many of you may already be up to date, with those changes, but for those of you that are new to the FQHC space or just getting involved or really just want a reminder on what's there, this is what we're here for. So important other items: the Consolidated Appropriations Act of 2023 was signed into law December 29, 2022, and that impacts both 2023 and future years for these changes that are effective. In addition, President Biden, May 11th, 2023, ended the public health emergency. That's really relevant with regards to its impact to telehealth and how telehealth was changed during the COVID era due to necessity. On the next slide.
On to our first polling question. When did President Biden end the public health emergency?
And this is real fresh news. So that should give you a hint on at least a month we're talking.
All right, about 30 more seconds. Reminder to get your votes in to get CPE credit. About 10 more seconds. All right, I'm going to close it out. And here are the results.
All right. Well, at least everybody's listening to the month and got most of that right. But May 11th was the answer. Just went into effect last month. All right. So again, that's relevant for telehealth purposes as it relates to reimbursements. But we'll talk about that in some future slides. So again, many of you already know this, but for those that don't, FQHCs uses what is called a prospective payment system, PPS system, for reimbursements. And under that system, Medicare pays the lesser of actual charges and the PPS rate for those services rendered to the Medicare beneficiaries for face-to-face visits. Again, with some changes more recently in the COVID area for telehealth, but we'll talk about that later. Under law, this is adjusted annually for market changes. In 2023, the base rate was increased to $187.19. That's up from $180 in the previous year, and represents, the largest increase since its inception in 2014. Although not substantial, certainly from a standpoint of comparability, it's a good increase, and that's relevant to centers bringing in more revenue. Certainly helps the cost get covered a little bit if you can meet that rate. However, applied to that rate each year is what is called a GAF, a geographic adjustment factor. Think of this as a kind of a cost of living adjustment based on the location of the center filing it. It's based on price indices, geographic price indices schedules that are updated annually. And for practical purposes, think of a center that's in Metro New York City. Generally, is going to be higher cost to provide services, and then supplies to keep that center doing what it needs to do, versus a center in rural Wisconsin. And so because of that, the adjustment factor intends to level out those reimbursement rates to offset higher costs in certain areas and lower costs. While it's certainly a good thing that current year's rate went up 3.9%, unfortunately, the sequestration rate is now back in play. This was kind of gone for a few years during COVID, but the 2% adjustment there, unfortunately, kind of offsets the 3.9% increase that was received. But those are some major changes in that center, or in the PPS reimbursement. So I just wanted to point out on the next slide that here's an example of what that gap adjustment rate schedule looks like. This is available on the CMS website. This is not the full schedule, but if you look at it, you can see, try to explain that, for instance, in Los Angeles, Long Beach, Anaheim, there's a rate of 1.065, which is applied times the current national base rate. So that rate would go up for a center in that area. In contrast, outside of Miami and Fort Lauderdale, the rest of Florida, line 99 on this schedule, they would have a reduction to their base rate based on their location. Now, these rates aren't perfect. There's going to be some areas included that have higher costs than other areas in that same area, but this is CMS's best effort to kind of level out the playing field. Move on to the next slide. So with regards to the changes, the patient base had some changes too, and some of these positive, not monetarily super substantial, but in an area in an industry where the patients could have financial needs that are substantial, every dollar counts. So the premiums that they pay for this year went down from $170 to $164.90. That's 3.1% reduction. In addition to that, the deductible paid on non-services paid outside of PPS, so non-PPS related services, went down from $233 to $226. Again, those are positive changes for our patient base that really could use all the changes possible. With that, we're going to move into some more relevant, more, I think, impactful information on the next couple slides, and I'm going to turn it over to Bamasa Baylor, who's going to discuss some of the changes and the other cost rates, as well as changes to the services included.
Thank you, Eric. Hello, everyone. My name is Bamasa Baylor. So on this slide here, you see some of the different service areas that are non-PPS services. And again, just to refresh, PPS is the prospective payment system. Typically, the services that are provided by FQHCs are covered within the PPS, and over the last few years, we've seen expansion of a lot of the covered services, mainly in different types of long-term care, mental health, and behavioral health care as well. So as you can see here, virtual communications and telehealth were also added to and expanded upon through the pandemic and over the last few years. So there's been a substantial amount of funds put towards getting reimbursements for those types of funds. Moving forward. Here's just a list of some of the services that are included that are considered non-PPS, so transitional care management, chronic care management, principal care management, chronic pain management, and then general behavioral health integration. And again, these are services that weren't traditionally covered that have now been added into the fold over the last few years. So moving along, the Consolidated Appropriations Act was the beginning of this act, these services becoming covered. So what that did initially was it extended provisions to FQHCs and other health centers to 150 days after the end of the federal health emergency, which, like our first polling question, officially ended May 11th, 2023. So what this allowed FQHCs and RHCs to do in particular was to allow payment and furnish telehealth services as a distant practitioner. It also allowed certain services to still be reimbursed for as audio only services. So really the flexibility within that was to allow these centers to have their services happen and kind of change their designation a bit. So that's what happened with that one. Moving forward. Next slide. Yeah, these are some changes, some other changes that came from Medicare the provider enrollment application fee, effective January 1st of this year, the new fee was $688. That you also were able to change where you were initially enrolling for a new location, revalidating Medicare enrollment where you were previously established, and new locations were added to the program as well. There was also revisions to the timing of payments for centers vis-a-vis RAP payments and other supplemental Medicare payments that were made. And this really just changed the billing cycles for the Medicaid and Medicare payments.
So, Bamas, I'll elaborate a little bit on that. So the fee, the application fee went up to $688 for all three of those areas, whether you're rolling a new center, adding a new location. So that's important because that's, the price of the application went up. For the final technical rule change, what this is trying to do, it revised the definition of what qualified for supplemental RAP payment that could be, reimbursed to centers to include mental health visits via telecommunication. That wasn't always there. So the technical change revised the definition to include these, whereas before it was strictly face-to-face visits that were allowable under the supplemental or RAP payments to the FQHCs.
Absolutely, yeah. So like Eric said, it really just added more of the mental health and behavioral health services to the fold of the stuff that was already previously included. Moving along, we have our second polling question.
All right, our second polling question. The Consolidated Appropriations Act of 2023 ended certain telehealth provisions through what date?
And we will speak more about the Consolidated Appropriations Act of 23 after this polling question. So this is really testing your knowledge coming into the question.
Yeah, it snuck in a slide earlier, but we're seeing how much everybody knows ahead of time.
About 10 more seconds.
I can assure you it didn't retroactively make it terminated prior to the year of the Appropriations Act, so that should help you take out one of those answers.
I'm going to close it out, and here are the results.
December 2023 is a good answer. However, as what we discussed, December 2024, some of them were extended even further out to give an extra year under the new provisions, specifically, telehealth provisions that existed under COVID.
Yes, just like Eric alluded to. So really, the Consolidations Appropriations Act of 2023 expanded upon what was put out there in 2022. The 2022 Act was really meant to take things through to the end of the federal health emergency. What this act did was extend some of those provisions, again, surrounding the telehealth and the behavioral health options to December 31st, 2024. So as you can see, with that, there was an increase in the Medicare physician fee schedule of 2.5%, and that'll go through December 31st of 2024. Other areas that were affected were the waivers needed for geographic and originating sites. There was also the eligibility of centers and of federally qualified health centers and the rural health centers for reimbursement under, telehealth and auto-only telecommunications. And there were also delays in the in-person visit requirements prior to mental health visits via the telecommunications technology.
And so I want to elaborate a little bit on the 2.5% increase to the physician fee schedule component. Each year, CMS evaluates, and under the neutrality laws, they are required to operate at a kind of neutral budget level, so not to increase Medicare spending past estimated amounts. So for 2023, the conversion factor was 0%, and there was an expiration of a 3% supplemental increase to the PFS payments for 2022. So the increase here attempts to offset that by providing a 2.5% positive adjustment for the calendar year 2023. It doesn't necessarily mathematically compute to that when you're taking everything considering, but again, it was an effort to offset what would have naturally impacted as a reduction, and by giving that 2.5% increase.
Yes, and lastly, effective January 1st of 2024, the FQHCs expanded the definition of the services included and that are covered to marriage and family therapists or other mental health counseling. Intensive outpatient services were also included. That 9-hour-a-week rule speaks to the patient needing to go to a physician and the physician recommending 9+ hours of outpatient therapy. So with these expansions came, certain restrictions and different requirements that were needed to be met, and that's just one of them there for the outpatient services.
And it's important for people going, using those services to make sure you have, what is called a qualified provider, and those are defined on, under the Act. In general, must have 2 years of clinical supervised experience in mental health counseling, certain degree requirements, so on and so forth, in addition to the 9-hour-a-week rule, which is actually a reduction from the previous similar rule, which was 30 hours. Moving forward quickly on cost reports, I'm not going to go too far into this. Nothing new here, just really just want to discuss some of the commonly misunderstood areas, specifically with telehealth, since still going to be, relevant going forward over the, the next year and next future years. Of course, these could always change with new updates, but basically, direct costs generally, relate to salaries and wages and other benefits. Those, typically come from the trial balance. But if you can't get to what the direct costs are for your telehealth visits, there's other options to get there. You could use a time study, which oftentimes is difficult to get it underway and get your team members to get those active and effectively done. Or what we see a lot is pro rata. We've seen this work, and CMS has taken this approach and been fine with it so far, and that's really just kind of pro rata total telehealth visits versus total visits to kind of exclude those. As far as the indirect costs, those should not be allocated. The indirect costs can remain on the line that they're already done. So again, you're only allocating direct costs to that telehealth line towards the bottom of the schedule on your cost report, and not the indirect costs associated with it. It's also important to remember when you're doing this, keeping your calculations of FTEs and visits accurate as much as possible. This is important, to exclude those portions of costs, whether you get reimbursed and how you use those in the schedule. But try to do your best in the best effort to get those accurately, because they're looking at things, and if things tend to stick out, you're going to see some adjustments coming back from your reports, which could negatively impact what you expect or what you have reimbursed or getting reimbursed. On the next slide, vaccine costs. Again, remember what goes into those. Those include more than just COVID vaccines for those that are kind of new, flu vaccinations, so on and so forth. The cost of the actual cost of the vaccine, if you're paying for them. In some cases, they're donated, which is great. But if you're actually paying for them, you know, the cost of those vaccines, that's the full cost. And there's a time component. How much time does it, you know, take for a practitioner provider to give that to a patient? And then relevant allocation of overhead. You know, again, there's no black and white way to do this, but you know, just keep your methods reasonable, supportable, and try to be consistent. And last but not least, aggregated revenue. You know, some revenue streams that are current that we still have coming through, depending on timelines. You know, PPP forgiveness revenue, provider relief funds. While those aren't really impactful to the reimbursement coming back to you or anything you have to pay going forward, the CMS likes to collect this data, and they're using this data to populate reports and make decisions going forward, just so they can see what other monies are coming in. So it's as important to keep that accurate and up to date as you know, the rest of the reimbursable information that impacts your payment. And with that, I'll turn it over to John Barry for a dive into 340B.
Thank you, Eric. John Barry, Senior Manager with Withum, part of our Healthcare Services Advisory team, which we have a 340B team ready to help. So I'd like to talk to you about two things real quick today. Quick first, you know, given limited resources, how can you best leverage the program and ensure that you're operating optimally but compliantly given constrained resources? And I'd also like to touch briefly on the New York State's recent legislative changes, how that could impact 340B, and how that could impact FQHCs specifically. So I'm going to move to the first slide there, Rachel. I think first, just a very quick brief update. You know, 340B, background on what it is. It's a drug pricing program it's a federal program that requires drug manufacturers to give discounts for outpatient drugs, significantly reduce prices for eligible entities. In order to be eligible, you have to go through, you know, register on the OPA website. I assume that most of the participants are familiar with a little bit of the background, but the purpose of the program really is to allow, you know, healthcare entities to stretch their scarce resources. And, you know, one thing that we always like to point out is that you don't always need to reinvest the benefits derived from the 340B program into the exact same point of care in which, you know, you got that 340B benefit. So the money is fungible, and then you're often, you know, the point of the program is to allow healthcare entities to provide more comprehensive services to patients. And so that's kind of a wide definition, and you can use these funds in a large number of ways, or a lot of different ways in order to benefit your patients. So, you know, moving on to the next slide, I just want to give a quick couple, you know, flow charts, illustrations, just show how the 340B program works. And then through these flow charts, it kind of shows how and why it can be difficult to remain compliant. And then, you know, with those difficulties of compliance, there's a lot of resources that go into that, and really making your compliance and your, you know, administration of this program as efficient as possible is important. So if you're looking at, you know, in its most basic circumstance, a patient goes into a covered entity, which could be a hospital or a dish hospital or an FQHC, and then they become a patient as long as an outpatient. And as long as that individual is defined as a patient, covers as the, you know, patient definition, they are then a patient of the entity and then qualify for 340B drug pricing. So if they're given, you know, whatever drugs they're administered in that outpatient setting, the hospital then, or FQHC, is then allowed to then go purchase those drugs from the drug manufacturer at a discounted price. They do that through separate drug purchasing accounts. The drugs are then replenished to the covered entity. A lot of times, I believe a lot of our crowd here would almost entirely would be outpatient drugs, so there's not a need for, you know, splitting or mixed billing, which some of the academic centers and integrated health systems or even medical centers, they have to do split billing and determine where that, you know, what drugs are purchased under 340B, GPO, et cetera. But if it's just an outpatient center, the majority of that can be purchased on outpatient 340B drugs. And then they get reimbursement, you know, that's undiscounted. So they get reimbursed by the payer, and there is no discount for the fact that you purchased the drug at 340B price. They get full reimbursement, which is important. So in this circumstance, very simple example, you know, you get reimbursement for the drug from a commercial insurer, in this case, for let's call it $100. If you can get a co-payment for commercial payment, that's another $10, brings you up to $110, and then you get a 340B discounted drug price of about $60, which leaves you with margin that could range between 40 and 60%. Now, if you're looking at that on a non-340B, maybe that drug cost goes up to $80, and the margins are significantly impacted, ranging in between what's called 5 and 20%. So it's a really meaningful discount, and the impact really it by drug indication, by service line, it varies quite a bit. But so moving on to the next slide, I think where a lot of the heartburn comes from is these contract pharmacy arrangements. And I think they've been cracking down on this quite a bit. The manufacturers are trying to crack down as much as possible on these arrangements. And you kind of talk through the flow of this, and we can talk through then the compliance implications and then the ways to expand your programs. So the way it works is an eligible patient has gone to a covered entity. They've been seeing providers there that qualify for all the 340B regulations and all the 340B requirements. So then they're a patient for that provider and that covered entity. They go into a contract pharmacy that's been registered, and there's a contract agreement established between the covered entity and that contract pharmacy. And so the patient goes in not really understanding or needing to know that they're a 340B qualified patient. The contract pharmacy dispenses the drug to that patient. And typically what's happening on the back end is there's a data feed that's occurring between the contract pharmacy and the covered entity. And there's often an intermediary or TPA that facilitates this process and basically is matching between the patients at the contract pharmacy and the 340B covered entity. So in this case, the eligible patient will receive certain matching requirements between that data feed, and the data feed will say, okay, this is a patient, they qualify for 340B drug pricing. At that point, the covered entity is then allowed to then purchase drugs from the manufacturer or wholesaler on their account. So at that point, they can then replenish the contract pharmacy's drug supply, which almost all that's done through virtual inventories on the back end. So they can replenish that. They purchase the drug. The drug is then distributed or sent back to the contract pharmacy to make them whole on the drug that they dispense to the eligible patient. Contract pharmacy then goes to the third-party payer and receives reimbursement. Again, undiscounted reimbursement. They receive full reimbursement according to the contract, and then that reimbursement is then passed back along to the 340B covered entity. The covered entity then makes the contract pharmacy whole through distribution fees or dispensing fees. And so, that's really what drives the incentive for the contract pharmacies to be able to do this. And ideally, there's an agreement that's reached between the covered entity, the contract pharmacy, and it has to be compliant with all the 340B regulations, and says, we have the dispensing fee typically has to be greater than the gross margin that the contract pharmacy would have received. Otherwise, they would have no incentive to do this. I think this is one of the things that starts to drive the heartburn with the program. One is that the contract pharmacies are some of your most well-known and largest for-profit organizations, such as Walmart, CVS, Walgreens, all the big box retail pharmacies that we all know. They all participate in this program, and they all have their own different systems and teams servicing the program. It could be a moneymaker for them. So that's the first thing. The next thing is around the distribution fees. Oftentimes the distribution fees can scale according to specialty. We've seen distribution fees that go up or down as a percentage of revenue. Oftentimes maybe they do not have a direct link or tie to the clinical intensity or the amount of resources that the pharmacy needs to expend in order to distribute the drug, or the complexity of using the pharmaceutical. So that's part of, I think, what's driving some of the concern around the manufacturers. And I know, frankly, sometimes even the covered entities that we work with have concerns with some of the contract pharmacy agreements and just choose not to do it because of some of the distribution fees and some of the gain shares and things like that makes people uncomfortable. So, making sure that this whole system and this whole patient flow, drug flow, and reimbursement is happening compliantly, one, takes a lot of resources, there's data in a lot of different places, and finding the most efficient way to do this is important in order to, one, expand the program compliantly. Expand the program, one, but then two, do it compliantly and making sure you're not stepping out of bounds. So your next slide, Rachel, I think if you look at the way that the different, all these different data silos can play out, people have to pull information from all these different, data silos, data parts. If you're part of the Walgreens program, you need to go and enter into Walgreens portal, pull information from there. If you're part of CVS, you have to do that again. You have to, in order to make sure that you're not losing prescriptions, you want to make sure that you're capturing everything you can. You need to go to the ERX, look at your e-prescription information, or in order to make sure that, do internal audits, you have to look at your encounter data, make sure that everything's registered to an OPA database. You have to look at your provider files, et cetera. And then if you just want to do some savings analysis, so that's just almost just to keep you, running to stand still. But if you wanted to figure out how you could actually improve and expand on your program, then you have to pull into drug information, drug charges, utilization, wholesaler data, figure out price deltas to really see where the opportunity lies. And all of this for an FQHC or for any healthcare organization with limited resources, it could become unwieldy. And so some of the things that we have helped our clients do and that we recommend is to automate some of these procedures, by using unique identifiers, coming up with ways to manipulate data on an automated basis, develop integrations, so that you can get this data flowing, in real time, or at least, if not in real time, then daily or monthly. So next slide, Rachel, kind of show an illustration of how we typically like to see these things, play out, and really what you're doing then is aggregating all these different data warehouses or data silos, try to build integrations or at least automate the process of pulling this information so that you can get it as quickly and efficiently as possible. And then you can pull that into a central data warehouse or an analytics engine that then allows you to match prescriptions to encounters, find ways to figure out where are my e-prescriptions going? Am I capturing all my e-prescriptions through either my contract pharmacies or hopefully preferably given everything that's going on, leveraging my retail pharmacy to the right amount in order to be able to make sure that you're getting the benefit that you deserve and that you're entitled to given the current regulations and rules of the program. And then from there, you can shoot out relatively straightforward dashboards and analytics through either a combination of Excel and, frankly, there's some really great front end tools available for very cheap prices, $7 to $10 a month if you're looking at Power BI. It's not difficult to learn and get up to speed. And what these productivity tools really allow is something that some of these large health systems might have full departments that are supporting the 340B program, but it allows like an FQHC or a smaller center to really start to automate this process, allow the financial team or whoever is supporting this program to focus on all the other tasks that they have to do on a day-to-day basis. And then also just think about, expanding the program. Where is my leakage occurring? Am I servicing all my patients the best way that I can? Are there certain ways that I can, instead of using a contract pharmacy, leverage some of my retail pharmacy assets? Or in another case that we've seen is even expanding that retail pharmacy footprint, bring it closer to where the patients are being serviced, the point of care, and maybe even have a satellite pharmacies close to, for example, in HIV clinics. We've seen, set up a satellite pharmacy right next to the HIV clinic where you can get that first fill and then find ways to then use the program to benefit you on the refills. So a lot said there, but it all really stems from getting the data into the right place efficiently and then analyzing it to one, making sure that you're compliant and making sure that compliance functions done as efficiently as possible. And then once you do that, then you can start to think about how you can leverage the program in order to expand and take care of your patients better. So, some of the 340B program infrastructure we'll show on the next slide here that's necessary, and some of the things that this can really benefit, just the policies and procedures. You need a robust set of policies and procedures in place. There's a lot on this slide. If you want if we'll probably share the slides, or you can reach out for any specific information on after the webinar. We're happy to share anything that we have. But policies and procedures are always important. How the drugs are procured, managed, how you're going to audit, basically outline how you plan to remain compliant, and then updating these policies and procedures on a regular basis, and use software as much as you can in order to leverage the program. Software systems, 340B management software, there's your wholesalers, all these other systems need to be done in a way that makes the program compliant yet efficient. And all that's kind of where I was mentioning is you get all these different data silos. Unfortunately, every time you add a new system in order to support something, it creates a new data silo. So finding ways to integrate with these systems seamlessly is important in order to remain compliant. And then which rolls into the next one, the compliance team, a team that, FQHCs might not have a team that you can just dedicate towards the 340B program, but at least assigning roles and responsibilities across the organization so that all the pieces that you need in order to remain compliant are under someone's roles and responsibilities. And having that team meet on a regular basis, having the stakeholders all aware of some of the things that you're doing in order to enhance the program, so on and so forth. That compliance team should be doing some sort of internal audit, depending on the where you think your weak spots or exposure might be within the program. Determine, just making sure that all the patients that you're giving 340B drug to are in fact eligible, especially in terms of your contract pharmacies or your retail pharmacies. A lot of that has to do with data feeds and making sure that those data feeds are correct. And also looking at eligibility windows. That's something that we've seen. How aggressive do you want to be after a patient is seen or an encounter has been registered at your covered entity? How long does that patient remain a patient? Is it 15 days, 180 days, 365 days, that you're allowed to continue to qualify? Contract pharmacy arrangements, obviously, need to make sure that they're compliant, have all those contracts, in a central place, make sure that, legal teams are comfortable with the way the dispensing fee and other arrangements are set up. And all this really just feeds into the 340B program integrity, and making sure that, I think within the FQHC community, it's more straightforward. You're making sure that you're doing this with integrity, but also with some of the larger health systems, making sure that as you use the program, be aware that at any time you want to be proud of the way that you use the funds, because we've seen a lot of these entities, more complex and financially well-off organizations using the program, which in a way that's considered as for-profit, and using it to expand into more wealthy neighborhoods as opposed to some of the localities that really need the funds, that really do have an underserved population, which is what the program was originally intended for. So moving on, I just wanted to talk on something that is relevant to, talk on when we do 340B optimization. I'll say real quick, some of the initiatives that we'll look at: selecting retail pharmacies, calling on underperforming pharmacies, specialty pharmacy and retail pharmacy strategy, and then just strategies to reduce leakage. Kind of touched on a couple of them throughout the discussion, but really, how do you position your retail pharmacy and how do you leverage those assets? You spoke about the HIV and the satellite pharmacies, something that a lot of FQHCs have looked at, they've seen in the past, but something that if you're not doing, you might want to consider as well. So moving on to some of the concerns, and specifically around, one of the 340B compliance issues is always around duplicate discounts. You're not allowed to take a duplicate discount. That includes the Medicaid. Medicaid, if you participate in Medicaid, fee for service, they receive discounts at the state level, and so you cannot be, you typically have to carve out your 340B drugs for Medicaid patients, fee for service. And recently, actually, we've seen some recent changes here in New York State. So it's been a long time in the making. I think in the next slide, we'll touch on it briefly. Long time in the making. It's been a little bit controversial, but on April 1st, 2023, the New York NYRX, the new pharmacy benefit program, under this model, they will pay pharmacy costs directly, and they eliminate the need for managed care organizations to administer this benefit through the pharmacy benefit managers. The idea behind it, though, is that the new process will create transparency and reimbursement to the pharmacies. it'll leverage the state's purchasing power to negotiate with the drug manufacturer and streamline administration for the practitioners. However, this has downstream, I can't even say unintended consequences for the 340, but it has, impact on the 340B program. What essentially we'll be doing is it's shifting the organizations that, that savings that would be, realized at the FQHC level is essentially being shifted over to the state level in New York. And it's really going to impact the FQHCs, the organizations that have a heavy payer mix that's shifted towards Medicaid, which, is typically the FQHCs as opposed to some of the more well-off in integrated health systems that have a more commercial payer mix. So, next slide, I can touch briefly on, the impact that they expect to have. There's advocates for FQHCs have said that this can have a really detrimental impact to the community health centers. They estimated losses of $260 million as a result of the carve out. I do believe from what I read that New York State said that they had earmarked $750 million about in order to make up for any Medicaid drug discounts, and I believe around $250 million of that was specifically targeted towards the FQHCs. So they're trying to make the FQHCs whole for their bogey that they're creating within the program. However, how this plays out over the long term is yet to be determined. It's only a month or two, since this has taken place. And we have a technical team that's kind of looking at this, keeping track of it on the back end and trying to, monitor how we can, help different entities with this process. So 75% of New York FQHCs responded that they needed to reduce or eliminate community outreach due to this program or due to this change in legislature. And 44% of FQHCs reported that decrease the number of delivery sites or hours. 80% said they would lay off staff. Those are pretty grim numbers if you're looking at that on its face. I think there's been, there's different perspectives on how this will ultimately play out. And the state believes that they're making everyone whole with this, with these funds, but to be determined how this ultimately impacts the FQHCs and their 340B programs and any unintended consequences that it might have in the future. So,
John, do you see this starting a precedent that's going to spread, to other states, or New York obviously politically is in the driver's seat a lot of things, as is other state out west, but what do you see as far as this impact?
Yeah, yet to be determined. I mean, I think when we're looking at it, we tend to consider it. We almost consider that a lot of this will be carved out, and Medicaid, regardless, whether it's fee for service or managed. That is our assumption going in. And so, we try to then you can look at the specific state and the specific circumstances and tailor an approach to that state. But it really is state by state. I think, a lot of the states that we've worked in the past, we've just carved out the whole thing and then tried to find ways to optimize it. So.
Great.
On to our third polling question. Which of the following reports are critical to reducing 340B prescription leakage? Reminder to get in your votes. Leave it up for about 30 more seconds so we can get to more of the content. About 10 more seconds. All right, I'm going to go ahead and close it out. And here are the results.
Great. Yeah, and the answer that I intended there was the ERX reports. And as I'm looking at the answer, reimbursement schedules could play a part into that to determine, the potential savings benefit. But if you're looking at it from a count basis, we typically use the ERX reports and go from there. So thank you.
All right. Hi, everyone, and good afternoon. We wanted to end the presentation today with a short refresher on the new lease standard, ASC 842. I know that many centers own their buildings, in which case this standard wouldn't necessarily apply, but also many lease other satellite locations, so we wanted to make sure that we touched on this. And we've already assisted many of our calendar year clients with the implementation. However, we also have many 630 and 930 clients that are gearing up for implementation. So we wanted, again, to give just a brief refresher and share some experiences that we've had so far. So we're going to talk about the changes in the lease classifications, understanding the lease accounting for operating and financing leases, and just a very brief case study example if we have some time for that. So moving on. At its most basic, a lease is a contract. It's a contract that conveys the right to control and use identified property, plant, or equipment for a specified period of time in exchange for consideration. And as I mentioned, the implementation is here. It was pushed back a few times, but it is officially here. And many of our 630 and 930 clients will be going through that process very soon. And we'll get to this on a further slide, but the basic mechanics of the new standard requires that all leases are brought onto the balance sheet. Capital leases are less affected just because they were already on the balance sheet under the pre-existing guidance of ASC 840, but operating leases are going to see the biggest change. And on the next slide, we have just a few details and exceptions that we've seen and dealt with some of our clients. So short-term leases are excluded. These are typically leases with a 12-month term or less and don't include an option to purchase the asset. However, you do also still have to disclose the total aggregated lease expense in your footnote disclosures, so keep that in mind. Next, and probably the biggest topic of discussion that I've had with many of my clients is the topic of renewal options, because many leases do have renewal options included in them. And the biggest source of confusion that I've seen has to do with the fact that the guidance uses the language reasonably certain to describe whether or not that option will be recognized. So what does reasonably certain mean? The guidance changed the language from reasonably assured to reasonably certain, which seems a little bit just like semantics. It's a very small change in the language, but it sets a pretty high bar. So it's somewhere around 75 to 80%, meaning that if you're 80% sure that you're going to exercise your renewal option, you should include that that extension in the calculation of your right of use asset and liability. Which, of course, we all know that understanding and quantifying the likelihood of a future event can be difficult. So there's just a few situations I wanted to share with you that I've seen with my clients. So first, I had a client that was 100% sure that they were going to exercise their renewal option that was in their lease. It was only for 2 years, and they had no plans to change the size of their staffing or scope of operations. So that one was really a no-brainer, and we included that, of course, in their calculations. Second, we had a client that was going to stay at their current office location, and they had a 10-year renewal option included in the lease. However, they were currently in negotiations with their landlord to expand their office space. So what we determined there is that that was going to constitute a new contract, and in that case, we did not include the renewal in their calculation of their right of use asset and liability. Those are two specific examples, but in conversations with many of our clients, there's so much uncertainty right now in terms of the economy and changes to more of a remote or hybrid work environment that they just can't be confident that they're going to exercise those renewal options, especially if it's for a long period of time. 1 year, 2 years, maybe, but a 10-year renewal option, 5 years, they just can't hit that 75, 80% bar. So it's a pretty high bar, and from what we've seen so far, we haven't really had to include that in our calculations and implementation. So on the next slide, we have a graphic that displays a decision tree as to whether to account for a lease as financing or operating. And if you're familiar with the previous guidance under ASC 840, you'll notice that it's fairly similar to the capital lease guidance. So under 840, capital lease designation required either transfer of ownership, a bargain purchase option, and then there were some more specifics about the lease term is greater than or equal to 75% of the expected economic life of the asset, or the present value of the lease payments is 90% or more of the fair value of the asset. So if you look at those first 4 blocks there, you see that they're pretty much the same. But I do want to point out that ASC 842 takes out that bright line of the 75% and the 90% thresholds. So those don't exist anymore. So management has a little bit more judgment there. There's also been a 5th and new criteria added for a specialized asset, meaning that if an asset is not expected to have an alternate use when the lease agreement concludes, it is treated as a financing lease. So if any of those criteria are met, you have a financing lease, and if not, your lease will be classified as operating. So moving on to polling question number 4.
4th and final polling question. True or false? Capital leases are now known as finance leases under ASC 842. All right, leave it up for about 40 more seconds. Reminder to get your votes in. We did have a few audience questions come in. We may not be able to get to them by the 1 o'clock end time of the webinar today, but we will be sure to have our team reach out to you to answer your questions. All right, about 10 more seconds for the polling question. I'll close it out. All right. Here are the results.
87% of you got the answer right. It is true. So moving on, Rachel, can we skip the next 2 slides just to be respectful of people's time? And the next slide, yes. So here, I just wanted to show, I was going to go through a very brief case study, but I just want to show kind of what a calculation of this implementation will look like for those of you that may not have gone through it yet. So here, the biggest thing to note is that you have to come up with a discount rate, which should be your incremental borrowing rate. For many of our clients that have existing debt, you can use that. If not, you can use a treasury rate that's similar to the length of your lease. Also note that if you have deferred rent, that's also going to be deducted from the value of your right of use asset. And on the next slide, because I couldn't fit everything onto one, unfortunately. So I wish I could show you the mechanics of how this spreadsheet works that some very smart folks at our firm put together for our clients' use. But you can see the green is just your payments, and then we use the effective interest method to calculate an interest component, and it summarizes all of the information here for you. So to implement this standard, you're going to need something similar to this. It doesn't need to be this exact template, but it's going to be something that looks similar to an amortization schedule. If you have a high volume of leases, there's also software that has been developed for this specific purpose to assist clients with the implementation of this standard and to calculate the journal entries and balances to put on their balance sheet. But Withum is also always happy to consult and assist with the implementation. So if anyone has any questions or would like assistance, we would be happy to help you with that. So, and with that, to be respectful of everyone's time.
Stephanie, I just want to highlight one item on that lease. And for those that are ambitious enough to draft your own financial statements, one of the common just slip-ups we see is when you're drafting the financial statements and what goes through on the cash flow statement and the impact has been, you know, the year-end December 31st, 2022 number. But it's important to remember that the actual asset being capitalized and the liability is upon implementation on January 1st. So in this case, it'd be the 460 and the 445, and then you have the amortization and imputed interest components that fall out during the year to give you your ending balance on the balance sheet.
That's a great point, Eric. Thank you. So with that, we thank you for your time, and we're happy to answer any questions. I'm sorry we didn't have time to get to them during the presentation today.
But we will follow up again individually with those who asked them, and we'll look forward to having those conversations.
Definitely. Thank you everyone for joining. And as a reminder, we will be sending out the recording and slides to all those who registered. And again, we will be sure to get back to those who asked questions during the presentation. Thanks everyone for joining, and have a great day.